Thank you, Dr. Deepamala, and those who attend in this session. Good evening, good afternoon, and good morning. This is the 2153rd day of continuous webinar conducted by International Forum for Promoting Homeopathy. Today, our guest is Dr. VAISHALI AVADHUT SHINDE. Let us begin the session with 1 minute silent prayer. Thank you all. The International Forum for Promoting Homeopathy comprises of homeopathic lovers, students, and doctors, and we have 3 sessions every day. The first session of the day is already over in Hindi from 7:30 to 9:30, and from 9:30 to 10:30 we have the international session in English, and from 9:30 to 10:30 we have a local language session in Malayalam. We are uploading the videos of the same on the very next day itself, so that those who missed the session can watch it again. You can subscribe the same without paying any money. You can share it with anyone who loves homeopathy. The purpose of this forum is to take homeopathy to every home around the world. And we have so far uploaded more than 3,900 videos at YouTube. You can search it at IFPH Homeopathy at YouTube so that you will get our previous videos. And let me come to today's guest, and it is Dr. VAISHALI AVADHUT SHINDE. She has completed MD and is working as the Associate Professor, Department of Repertory, late Mrs. Hausabai Homeopathic Medical College and Hospital, Kolhapur, Maharashtra. And she's a wonderful personality, having very good practice. And today, Doctor will be talking about from cause to cure, a repertorial approach to causation in homeopathy. As we all know that there are different methodology of enriching simillimum, and the most important thing is knowing the cause behind the illness. There is another theory called cause and effect theory. Of course, what we are seeing in front of us is the effect of something. That is, so it is better to know what is the cause and how to read the simillimum by using repertory. That is what Dr. VAISHALI SHINDE is about to present in front of us. So we proudly welcome the guest of the day, Dr. VAISHALI SHINDE. Welcome, Doctor. You can begin the session. You are co-host now. Please unmute yourself.
So good evening all. It is my privilege to present my topic, that is cause to cure, repertorial approach to causation in homeopathy, in front of all of delegates. Thank you, sir, for my warm welcome. So let me share my screen.
Yes, yes.
Sir, will you please open my PPT?
Yes.
I'm unable to find it now.
Actually, you have shared it in
yes,
a...
Yes.
And
yes, I found it. Okay, no problems. Okay, so today's my topic is cause to cure, a repertorial approach to causation in homeopathy. Myself, Dr. VAISHALI SHINDE. So let me start.
Please open the video.
Yes, sir.
Slide. Please open the slide. It is still not open.
Not open?
Not open. From cause to cure webinar. You just click on that so that it will open.
Yes, sir.
Not yet open. It is. Actually, it was there when you started beginning.
Now, is it?
No, it is. You may do one thing. You may stop sharing and restart again.
Okay, sir. Is it? Is it looking?
No, it's good. It's fine. Oh. It's fine. It's full screen.
Okay, sir. So let's start with. So every disease has a story. Every story has a cause. Every cause has a remedy if we know where to look. So have you ever prescribed the seemingly indicated remedy and still failed to cure the patient? Sometimes the missing piece is causation. So today's our learning objective is understand Hahnemann's concept of causation, differentiate various types of causation, explore the elements from rubric in repertory, select the appropriate causation rubric, apply the causation in clinical practice. So before we begin, let us define what we hope to achieve by the end of the session. This webinar is not simply about the elements from chapter. It is about understanding the philosophy behind the causation, appreciating how great repertorians interpreted it, and learning how to apply it systematically in day-to-day clinical practice. So by the end of the presentation, I hope you all will be able to recognize the clinically significant causes, translate them into repertory rubrics, and integrate them with the totality of symptoms. So rather than beginning with the theory, let us begin where every homeopathy consultation begins, that is with a patient. So it is a case, a 42-year-old male farmer visited the OPD complaining of severe pain in the lower back, radiating to the right buttock, posterior thigh, calf and heel for the past 3 days. The pain was sudden in onset, shooting type of pain in nature. It is associated with tingling and numbness in the right foot. Patient is having difficulty in upright position and walking. There was aggravation by initial movements, walking, standing, bending forward, amelioration by the absolute rest, lying on the unaffected side, and warm fermentations. On examination, the SLR test was positive at 35 degree, and lumbosacral region tenderness was there, and MRI also showed the prolapse disc changes. So let me ask, which remedy comes to your mind first? Is anyone can answer the remedy? Okay. As per my yes.
You can write in the chat box.
Okay. Oh, okay. Let me suggest. It could be Rustox, Bryony alba, Colosynthis, Arnica montana, Hypericum. But if I add one sentence in the above case, that is if the patient is telling, doctor, the pain started immediately after I lifted a 60 kg sack of fertilizer while working on my farm. This one sentence can change our thinking process. Initially, by looking after only the signs and symptoms, we come to the remedy at conclusion. But if I add this sentence or by the patient, that is simple cause, it can change the remedy selection. So we should first ask, why did the patient become ill, rather than what disease does we have. That is not mere symptomatology is important, but the cause behind that symptom is much more important. So in this case, the big pain began immediately after lifting a heavy sack is the single piece of information which transfers our case. That is the exciting cause, which is lifting the heavy weight. It is not merely a single symptom, but it is a characteristic feature of the case which can channelize our remedy selection. So today's our topic is concept of causation. As per our learning objective, we go through the our master's concept behind the causation. That is firstly Dr. Hahnemann. So Hahnemann taught us what to look for. That is concept of causation. Hahnemann was always at a great pains to emphasize the importance of the causative factors in the environment, both physical and emotional, which could be held responsible for the development of illnesses. So he advises to take the cause. Now let's understand this by few examples. That is, first example is a 28-year-old woman. She developed a severe migraine for the first time 15 days after the sudden death of her father. Before that event, she had never experienced the migraine. This is one case. What is more important here in this case? The diagnosis of migraine is the fact that it started after the grief. So in this case, the diagnosis is a migraine, but the exciting cause behind the migraine or headache is a grief that is most important. So the exciting cause individualizes the patient, because there are so many patients of migraine, but the cause is an individualizing factor in that case. Another, if we see the another case, that is a 10-year-old boy developed a severe eczema after separation of a skin eruption with steroid cream. In this case, the exciting cause is, what is the exciting cause? That is separation of skin eruptions. So in this case, the diagnosis is eczema, but the cause is suppression. That is, we should investigate that what happened before the disease appeared. Another case, a healthy businessman never had hypertension. His business collapsed. Within 3 months, he developed a sleeplessness, anxiety, and high blood pressure. So we see in our OPD there are multiple patients of hypertension, but in every case, we should understand that is why it developed. Then if we see for the another case, developed a recurrent urinary tract infections immediately after marriage. So in this case, we should merely see the complaints of UTI, or should we investigate the cause? That is, immediately after marriage, if she develops the urinary tract infection, that incidence may be the cause. Another, if we see the another case, that is a college student. She had never any panic attacks before. One day she met with a road traffic accident. Though she didn't harm physically by that road traffic accident, but since then she has the panic attacks, fear while traveling, nightmares, palpitations. She can't travel again after that incident. That is, in this case, the diagnosis is of anxiety disorders, and the cause is a fright. If we see the another case, that is a farmer developed a severe gastritis after taking painkillers daily for 6 months. Is gastritis the disease? Yes, in this case, the gastritis is a disease, but what caused it? That is drug abuse. So, if we summarize all these six cases, if suppose arrived at our OPD, that is, in first case, one developed a migraine after grief. In another case, one developed eczema after the steroid. One developed a panic disorders after the fright, that is her accident. One developed a gastritis after prolonged analgesic use. One developed arthritis after exposure to cold and damp. And another developed asthma after emotional shock. These are the 6 different cases. There are 6 different stories. Dr. Hahnemann teaches us that the story behind the disease is often more valuable than the name of the disease itself. That is why Hahnemann instructed the physicians to investigate not only the symptoms but also the exciting and maintaining causes of the illnesses. So this is the summarized story of the aphorism number 5, in which Dr. Hahnemann taught us about the exciting cause. So in each and every case, we should investigate about the cause behind that illness, not merely the symptomatology. So the physician must consider in each individual case of the disease, not only what are the symptoms, but also what has produced them, what maintains and aggravates them, and from the totality of symptoms, the history of the chronic diseases, we should select the similar remedy. So the main factors of causation, there are 5 components, that is exciting cause, fundamental cause, constitutional cause, lifestyle habits, and social and domestic factors. So I'm not going to read about aphorism number 5, but in aphorism number 5, Dr. Hahnemann have given the components of causations. So if we go in detail about the exciting causations of or components of the causation, first one is a exciting cause. That is, what we should ask for the investigation of exciting cause, that is, we should ask what happened immediately before the illness began. There are few examples of exciting causes, that is grief, fright, injury, exposure to cold, vaccination, overexertion. So these exciting causes, if we investigate, they identify the trigger of the disease and often provides a characteristic symptom for the repertorization. Second component is a fundamental cause, that is the miasmatic cause, which is leading to a true chronic diseases. In such cases, we should ask to investigate the fundamental cause, that is, why has the patient become chronically ill? If the patient recurrently having one single complaint and we are not getting the complete cure, we should investigate about the fundamental cause. In such cases, underlying miasmatic background, constitutional susceptibility, genetic predisposition behind that particular disease, and long-standing influence of that disease, we should investigate. Again, third component of the causation is the individual constitution. So every person reacts differently to the same exciting cause. That is, one develops migraine, another develops asthma, a third develops depression after a same causative factor. Why it happens that every person have the different presentation? Because their constitution and susceptibility differs. Then fourth component of the causation is a lifestyle and habits. The examples of the lifestyle and habits, that is smoking, alcohol, coffee, sleep deprivation, sedentary habits, diet, occupational hazards, etc. So these are the maintaining causes of the diseases. Then last component of the causation, that is social and personal factor, that is occupation, family relationships, financial stress, marital problems, domestic environments. These influences both disease expressions and recovery. So notice that Hahnemann does not begin with the laboratory reports or diagnosis. He begins with the patient as a person. So aphorism number 5 teaches us that successful prescribing depends on the understanding and circumstances surrounding the illness, the individual's constitution, and the factors that continue to influence the disease. This holistic approach remains one of the defining principles of homeopathic case taking. So let me explain this with a example. That is, in a OPD, if a patient one develops comes to us with a complaint of insomnia after the sudden death of spouse, and another patient that same complaint, that is sleeplessness after working night shifts for the 6 months. So in both the cases, the diagnosis is same, that is insomnia. So the disease is same, but cause in both the cases is not same, that is different. So can we prescribe the same remedy for the both the complaints, both the patients with the same complaint? Not necessarily, because this illustrates why identifying the exciting and maintaining causes is essential for individualization. So every disease, from all the slides we learned that every disease has a history, every history has a cause, every cause has a repertorial value. That is, aphorism number 5 provides the philosophy, and the repertory provides us the guidelines for the rubric, that is elements from, that is Hahnemann's concept of causation into repertorial language, enabling us to convert the patient's history into repertorial language. So why causation matters? There are two scenarios. The lines of management of the or prescription. For the first one, if we have the patient having the particular disease with a particular clinical feature, if we diagnose the case and prescribe on that basis, that is basis of diagnosis, we not that treats the disease expressions only, we cannot achieve the cure. We may get the relief, maybe temporarily. In another case, if we have a case with a particular diagnosis, and if we investigate the causations, we individualize the case depending on that causation and give the prescription. Here in this case, that we treat the root cause leading to true and lasting cure. So we should choose the second one, that is we should go with the individualization rather than prescribing on the basis of diagnosis. So that was about the exciting causes. Dr. Hahnemann also given the maintaining causes, that is aphorism number 7, in which he says that emphasizes that physicians should identify and remove all the maintaining causes whenever possible, because exciting causes the acute conditions, but in so many chronic conditions, the maintaining cause is a basic blockage that prevents the cure. So in spite of the prescribing the similimum, we didn't get the cure because the maintaining cause is blocking that cure. So a remedy acts best when obstacle to cure are removed, that is the maintaining cause should be removed. Suppose a patient suffers from a chronic gastritis. You prescribe the perfect similimum, but the patient continues taking painkillers 3 times a day. Will the remedy work optimally? Probably not, because the maintaining cause is still active. Here are a few examples of maintaining causes. We face in day-to-day our clinical practice. There are so many patients having gastritis, and they continue to taking the NSAIDs or painkillers daily, 3 times a day, 2 times a day, and they complain about the gastritis. If we see only the gastritis and prescribe the remedy, we couldn't achieve the cure. So we have to remove that maintaining cause. Also, we face the patients of asthma who continuously exposing to the allergens. So we have to identify that allergen which is maintaining cause of the disease. Until and unless we remove that maintaining cause, we cannot cure that patient of asthma. Again, low back pain patients having poor ergonomic posture, so we have to correct that posture. Also, the mobile use or computer these are the maintaining causes. So many patients of insomnia having the night shift duties, we have to correct them. Chronic headache patients, excessive coffee intake or stimulants, we have to correct. So removal of the maintaining cause is also that much important. Dr. Hahnemann reminds us that medicine alone cannot overcome a continuously operating obstacle to cure. Also, in Hahnemann's approach, as we see the exciting and maintaining causes, Dr. Hahnemann also given directions about the identification of that causation. That is, case taking is important. So art of discovering the causation is also important, which is explained in aphorism number 93 and 94. That is, when, why, how, after what we should ask the patient. So Hahnemann instructs the physicians to obtain the patient's history carefully, patiently, without interruption, in chronological order. So causation is rarely volunteered by the patients. This not doesn't happen that each and every time patient comes to us and tells the causation that this happened and I got that complaint, that happened and I got to that complaint. The patient doesn't every time patient doesn't volunteer the causation of that case. So we must discover it. A good case taking is actually a good detective work, and as a physician, we have to collect the clues and connect them and find the connect the events and then reach to the simillimum. So never ask what are your symptoms, but we should ask what changed in your life before your illness begins. So Dr. Hahnemann also recognized that many diseases begin not only in the body but in the mind. So that was Dr. Hahnemann's approach. This is not a modern concept. More than 2 centuries ago, Dr. Hahnemann recognized that understanding the origin of disease is fundamental to successful prescribing. So, Dr. Hahnemann taught us what to look for. The next question is, how do we apply this principle in practice? So, Dr. Boningason showed us that a definite exciting cause can become a valuable guiding symptom provided it is integrated with the complete symptom. So, he transformed the causation from an observation into a repertorial method. So Hahnemann introduced the concept of causation and Dr. Boningason transformed it into a practical tool for prescribing. So how he practically applied, that is he given us the concept of complete symptom, that is location, sensation, modalities and concomitant. So integrated causation into repertorial analysis, making it practical prescribing tool. He also added so many rubrics of causation, that is elements from in his repertory, PPB, etc. Also, Dr. Boningason given 7 essential questions, that is quiz, quid, UBI, cubis, oxalis, cure, condo, comodo. So, in that, the cure is the point in which we have to ask the exciting causes, maintaining exciting causes such as grief, injury, exposure to cold, suppression, modifying factors. So, causation as a guiding symptom. Dr. Boningason believed that a definite, reliable, exciting cause is often one of the most characteristic features of a case. He observed that patients frequently remember how their illness begins more clearly than they describe the sensation or modalities. So he has given many examples like neuralgia after extraction of tooth, migraine after grief, rheumatism after getting wet, dysentery after eating spoiled food, asthma after exposure to cold, etc. in his repertory. Dr. Boningason transformed causation from a philosophical observation into a practical repertorial tool, demonstrating that understanding why a disease begins is often the first step towards finding the simillimum. So that was about Dr. Boningason. Then Dr. Boger reminds us that the physician should not collect the symptoms randomly. Every symptom has a beginning, an evolution, and a relationship with the exciting causes. Dr. Boger regarded causation as one of the strongest guiding symptoms in homeopathic prescribing, provided it was definite, characteristic, and confirmed by the totality of symptoms. Dr. Boger advocated that when a definite cause is clearly established, it may become one of the most valuable guiding symptoms. Dr. Boger's philosophy. So Boger believed that successful prescribing depends upon recognizing the sequence of events in a patient's illness rather than merely collecting isolated symptoms. So Dr. Boger emphasized what happened, what did it happen, what changed after that event, how did the disease evolve. Thus, Boger viewed causation as a dynamic process, not simply a historical fact. So causation as a characteristic. According to Boger, a definite exciting cause frequently becomes a guiding symptom, especially when the relationship between cause and disease is clear. Symptoms appear shortly after the exciting event. The patient's individuality is reflected in the response to that cause. So causation should never be used in isolation. It must always be confirmed by generals, modalities, concomitants, and pathological generals. So Dr. Boger has emphasized on the causations, not merely the causation, but the complete picture of the disease should be collected. That is, the individual, that is reaction of the patient is also important according to Dr. Boger. So etiology, which tells us why did the disease begins. Modalities tells us under what conditions it is better or worse. And pathology, that is what structural or functional changes have occurred. And Boger integrated these 3 elements to reach the simillimum. So, according to Boger, the sequence of cause, that is evolution of disease, is more important rather than a single cause. A characteristic expression is often more valuable than a mere list of symptoms. So that is, if we go to differentiate between the Boningason's concept and Boger's concept, Dr. Boningason emphasized more on the complete symptom, that is causation should be asked, but Dr. Boger emphasized more on the focus on the evolution of the disease process, that is from cause to symptoms and the pathology. So clinical chronology and individualization is more important according to Dr. Boger. So Boningason taught us to complete the symptoms and Boger taught us to understand the evolution of the disease. Now if we shift from the Boger's concept to the Kent's concept, Dr. Kent shifted attention to the inner life of the patient, giving more importance to the mental and emotional causations. These complementary approaches ultimately culminated in the comprehensive elements from chapter in the repertory. So Dr. Boningason what caused the disease is important according to Boningason, and how did the disease evolve after the cause, that is chronology plus pathology plus modalities are important according to Boger. But Dr. Kent, how did the patient react to the cause is important according to Dr. Kent. So Kent's approach to causation, the mind as the primary expression of the disease. Dr. Kent regarded causation not merely as an external event but as the patient individual reaction to that event. The same cause may produce different diseases in different individuals because each person possesses a unique susceptibility. So in Kent, if we go through the Kent's repertory, there are so many rubrics has been explained under the Kent's repertory, like elements from grief, elements from fright, anger, mortification, disappointed love, jealousy, anxiety, mental shock. These are so many mental emotions conditions which leads to different types of diseases. So Kent believed that emotional disturbances often represent the deepest level of disease expressions. So Dr. Kent believed that the mental symptom reflects the deepest disturbance of the vital force. Therefore, mental causations frequently possesses greater individualizing value than the physical symptoms. It is another example of same case of insomnia, that is a patient which we've seen previously, that is first case having the causation as a after drinking excessive coffee, and another case we have seen previously, that is after sudden death of a child. In both the cases the complaint, that is insomnia, is same, but the cause is different. So if we prioritize the cause, the emotional cause is more important or much more deeper than the physical cause, that is excessive coffee or etc. So Kent would attach much greater importance to the emotional causation that rather than physical causations. So when a mental cause is clearly related to the onset of a disease, it occupies a high position in Kent's hierarchy. So Kent teaches us that causation alone never explains the patient. The same exciting cause may act upon many individuals, yet only those with appropriate susceptibility develop diseases, and each expresses that disease in a unique way. So this is the hierarchy of explained by Dr. Kent. That is, mental and emotional causes should be given the high importance rather than particular causes, and lastly the pathological changes should be seen. So mental is the highest level, second middle level as that is particular symptoms, and the pathological changes, that is lowest level, shows the physical or anatomical alterations in the body. Dr. Kent's greatest contribution was not simply the expansion of mental rubrics, but he demonstrated the physician that how to understand the patient's emotions influence the entire disease process. So again, if we differentiate between all these three stalwarts, that is Boningason's concept, Boger's concept, and Kent's concept. Dr. Boningason emphasized that is causation as a guiding symptom. So asked what caused the illness. Dr. Boger emphasized chronology and pathology, that is how did the disease evolve from the causation to the pathology, that is causation integrated with time and pathology. And Dr. Kent emphasized susceptibility and mental reaction, that is how did the patient react to that particular causation. That is reaction of patient is also important, and which is interpreted through the patient's constitution and mental state. So at last, and conclude with the Kent taught that the significance of an exciting cause lies not merely in the event itself, but in the unique way each patient responds to it. That is, the reaction of the patient is more important. So repertorial approach, a causation becomes clinically valuable only when it is transformed into a repertorial rubric and interpreted in the context of the totality of symptoms. So sources of causation in a case. Not every patient comes to us and say that is the I have a complaint after that particular causation. For example, I became ill after grief. the physician is the one who has to discover it. As I previously said, that we should work like a detective. We should investigate the cause. So we have to go through different sources of causation, that is the history of presenting illness, which told by the patient. Also we should go through the past history, what happened previously before that illness, etc., that is past history. We also go through the mental history of the patient, that is what is the emotional condition of the patient at the time of the illness or before illness. And then also the occupational history that we described before, that is maintaining, we should investigate for the maintaining cause. And also the lifestyle changes and drug history and environmental exposures. So many exciting causes are hidden. Good case taking reveals them. So these are the elements from various types of examples of rubric elements from, that is in mental, there are grief, anger, fright, stress, etc. In physical causations, that is injury, fall, overleaf, fracture, sprain, strain, burns, wounds, etc. In environmental, cold, damp, heat exposure, noise pollution, dryness, high altitude. And also in hydrogenic, that is vaccination, steroids, surgery, antibiotics, medication overdose, diagnostic error, etc. So never use causation simply because the patient mentions an event. Instead, one should confirm whether is the chronology correct, is the cause definite, is it characteristic, does it explain the onset, when should we use the causation. So as I told you, each and every case we should not take the causation as told by the patient, but we should take only if it is having a definite exciting cause, or it is a sudden onset of an event, or characteristic mental trauma, or definite physical injury, or drug suppression, or any vaccination, or any occupational exposure. If any one of these is available, then we should consider it for as a causation, rather than if we have any vague assumption which is told by the patient, or any coincidental events or causes without chronological relation, that is no relationship between the onset of disease and the particular cause, then we should not take it as a causation. Also unsupported patient's beliefs. So if patient says my arthritis is because of my neighbor, we should not consider it as a causation. Though patient is describing it as a cause, we should investigate it thoroughly because it doesn't have any repertorial cause. Repertorial place. How to select the correct causation rubric? From patient's history to the right repertorial rubric, we will see the correct the few steps for the identifying the causation and taking it as a rubric. So firstly, we have to classify the cause, that is whether it is mental, physical, environmental, and heterogenic, because the mental causes are much more important rather than physical and environmental causes. Also, we should confirm the chronology plus causality and characteristic nature. Then we have to convert the patient's cause into the repertorial rubric and correlate, that is with the patient's constitution and physical complaints. Because not every event in a patient's life qualifies as a repertorial causation. A causation rubric should be selected only when there is a clear and clinically meaningful relationship between the event and the onset of the disease. So there are few steps for the identification of the cause and till the cure. So firstly, we have to ask the patient, what happened before your illness began? When did it happen? Was there any physical injury, emotional shock, exposure, or suppression? So these are few examples. That is, if a patient tells my migraine started after my father's death, my asthma began after exposure to cold and wind, my back pain started immediately after lifting a heavy object. These are specific events which are clearly describing the cause behind or exciting cause behind that particular illness. So we have to identify the event that occurred immediately before starting of the illness. So second step, we have to confirm the chronological relationship. That is, the cause must precede the disease. So in incidence one patient came to us with a grief since 15 days grief, so particular incidence, and after 15 days patient started migraine. In this case, the strong causal relationship is there, because immediately after that incidence patient has developed a migraine, before which patient was not having any complaint related to migraine. And in another incidence, patient same complaint of migraine, and patient tells in while taking the past history that father's death before 6 months. So in both the cases, the cause is the effect is migraine and the cause is grief. But in first case, that is immediate cause, and the second one, that is there is a so much gap between two evidence. So grief cannot be considered the exciting cause of migraine because the disease existed before the event. So the third step, that is the cause. We have to investigate whether the cause is definite. That is, we should confirm the cause. A causation should be clearly remembered by the patient. That is, it should be told by the patient. Then closely related to the onset of illness. That is, it shouldn't be that is incident to, that is before 3 years. Since 3 years patient is having migraine, and after 6 months of the, that is death of the father. So it shouldn't be irrelevant to the onset of the disease. It should be closely related to the disease of onset of the disease. So consistent with the clinical history. The pain started immediately after a fall. The eczema appeared after prolonged steroidal application. These are the linkage between the cause and effect. And in, if we should not take that is, if the patient tells, I think my arthritis is because of my bad luck, or patient tells someone cast an evil eye on me, these are the beliefs, not clinically verifiable causes. So in such cases, we should not take them as a cause because patient tells, but we have to confirm the cause. So our next step 4 is convert the history into a repertory rubric. For example, if the patient tells us my complaint started after grief, that is, rubric is elements from grief. Since the fright, I cannot sleep, the rubric present in repertory, that is elements from fright. If a patient tells that pain began after lifting a heavy weight, the rubric present in repertory, that is a generality section, that is rubric exertion or lifting. Then skin diseases developed after vaccination. In generality section, vaccination after is a rubric available. So our role is to translate the patient's own words into language of the repertory without altering the meaning. The patient does not speak in rubrics. The patient speaks in experiences. The physician's art lies in translating those experiences into the language of the repertory without losing their original meaning. So as a physician, we should identify the cause and convert them into the rubric repertorial language, and then reach to the simillimum. Then our next step is confirm with the totality. This is the most important step, in which we shouldn't prescribe on the basis of causation, though causation is important, but always we confirm with the other complaints of the patient, that is mental general complaints, physical generals, modalities, characteristic particulars, and concomitants also. So the patient presents with a migraine after grief, having desire for salt, reserved personality, worse in the sun. In this case, now migraine after grief is an important symptom, but other particulars means other general symptoms are also important. So we have to prescribe on the constitutional approach, that is complete picture of the disease, that is totality, not only on the causation alone. So decision tree, that means how we should proceed from cause, that is, if patient reports a cause, we have to identify the relationship between the cause. If there is no any relationship, do not use that cause as a prescribing agenda. If there is a clear cut relationship between the cause and effect, that is disease and disease progress and the cause, then did that symptom begin after the event, we should identify, and then only we confirm with the totality, that is other symptoms, and then correlate and repertorize. So I have a case, all this we see with the clinical example. One case, a 32-year-old woman presents with anxiety. If she says, doctor, my anxiety began after losing my job, should we immediately select the remedy? That is rubric elements from disappointment? No. So we have to ask, when did you lose your job? When did the anxiety start? Were there any similar complaints before, that is before previously, if she had any anxiety, etc., or what are your mental and physical generals? All these questions should be asked, that is the case should be interrogated thoroughly, not only in first saying if the patient is giving the cause and we have to prescribe on that particular cause, but instead we have to take all the symptoms from the case, and then only we have to confirm the chronology between the cause and effect, and then only we should prescribe the remedy. So there are common errors while prescribing on the basis of causation are: The first one is a selecting a rubric because the patient merely mentions an event, as we previously seen. That is, my joint pains appear after my due to my neighbor, etc. So we should not take them as a causation just merely because the patient is telling us, but we have to confirm it whether it is a really related to that particular disease. Then ignoring the chronology, that we should not ignore the chronology. That is, the onset of disease and the cause is also important. That is, the cause must precede the onset of the disease. There is a chronological relationship between the disease and the cause. If the patient is having the same complaint previously and the cause which occurred after that in between, so we should not take that as a causation, but the cause should be definite behind the onset of the disease. Then using causation without confirming with the totality. So we should not prescribe merely on the causation. We should confirm it with the totality of the patient. That is, other physical generals, mental generals should match with our totality, match in our simillimum. Then overlooking the maintaining causes. Also, if we prescribe the simillimum remedy only on the present totality, but we ignore the maintaining cause, or we don't remove the obstacle between, we can't complete the cure. Then translating the patient's word into incorrect rubric. It is also an important point or mistake we should avoid, that many times we interpret each patient's history into incorrect rubrics. That is the major error between major error for the prescription. So all through the slides, we learned that a causation rubric should never replace the totality. It should strengthen it. That is, a causation should be a part of totality, not a single symptom for the prescription. So patient's history provides the story, the repertory provides the language, and the physician provides the judgment. The art lies in selecting the rubric that faithfully represents the patient's experience while remaining consistent with the totality of the symptoms. So these are the common mistakes. Mistake 1, prescribing of the causation alone, ignoring the chronology, ignoring the maintaining cause, choosing the smallest rubric, that is, specificity can lead to astray. Then ignoring the constitutional symptoms, ignoring the mental generals, and using the diagnosis instead of causation. These are the common mistakes in repertorization. So case history: a 38-year-old female school teacher consulted for a recurrent migraine of 8 months duration. She described the headache as a throbbing, predominantly left-sided, associated with nausea, photophobia, occurring 2 to 3 times per week, relieved by lying in a dark, quiet room. She had previously received symptomatic treatment with only temporary relief. During detailed case taking, initially she only complained of headache. When asked, when did this headache first begin? She replied, about 8 months ago. My next question was, did anything significant happen around that time? She became emotional and remained silent for a few moments before saying, 8 months ago, my husband suddenly left me and our 2 children. Since then, I have been under constant emotional stress. I worry about the children's future, cry when I am alone, and I have never felt the same again. The headache started about 2 weeks after he left. So, in further inquiry, the patient was having frequent silent weeping, aversion to consolation, brooding over the past events, sleeplessness due to persistent thoughts, headache aggravated after emotional upset. So, diagnosis of that case is migraine, but diagnosis alone does not individualize the patient. So I have not prescribed on the only diagnosis, that is migraine or particulars of the headache. But in this case, the main my approach was on the life event, that is headache headache is not merely migraine, but the history of the patient was the major important part of that case. So in according to my repertorial interpretation, I took the rubrics like mind elements from grief, mind weeping alone vain, mind consolation, aggravation, sleeplessness from grief. So elements from grief was the one of the component of my totality. So patient's language, my husband left me, I haven't been the same since. So clinical interpretation of that particular incidence, that is mind elements from grief, because it is a clear-cut emotional trauma with definite chronology. Then I have confirmed it with the other mental generals, physical generals, headaches, modalities, and concomitants. And then I prescribe the particular simillimum. This is another case. Recently, I have seen my OPD. That is a 12 years female a child where she was studying in 6th standard, and she came with the complaint of eruptions around the umbilicus and groin regions in 6 months. She was apparently all right before 6 months. Suddenly, complaint started with itching in groin region and eruptions. After a few days, the eruptions appeared over the abdomen around the umbilicus. The aggravation by during playing due to perspiration, aggravation at new moon, aggravation at night, and amelioration at morning. There were no any specific personal history. Only she was having desire for sweets and ice creams and unsatisfactory bowel habits. Thirst was for large quantity at a small quantity at large intervals. While investigating the mental state of the patient, she explained that she is the more about the she's ambitious, and the incidents she told about that now recently she appeared for the Navodaya exam, which is very stressful for her. Incidents, that is, she feared for the exam, and she has a lot of anxiety and tension about that exam also. Since then her complaint started slowly, that is the pain and itching started. But while the result came out about that exam, and she's come to know that she scored very less in that exam, the complaints aggravated, that is the eruptions were flourished. Also, as per my observations, she was talking like a woman, that is precautious, and she was looking like a mature woman. So in that case, my diagnosis was Tinea nigra, and I have taken the rubrics from the above history, that is elements from bad news, elements from anticipation, mind ambition increased, precocity of the children, generalities, ice cream desire for, sweets desire for, new moon aggravation was the also thing, and tendency to take cold easily, and eruption, that is particular symptoms also I have taken. So this is my repertorial result after repertorization. So that is the follow. In this case, these are few images. This is the first follow. The eruptions were blackish and etc. And after the final prescription given upon that totality, she met with the result. So our learning objectives were, that is, we traveled from through Hahnemann's philosophy, the repertorial insights of Boningerson, Boger, Kent, and finally the practical application of the synthesis repertory. So my message was from all the slides, that is, causation is not merely an interesting historical detail. It is often the key that individualizes the patient and guides us towards the simillimum. So my learning objectives were understand the Hahnemann's concept of causation, differentiate various types of causation, explore the elements from rubrics, appropriate causation rubric, and apply causation in clinical practice. So I think I have tried my best to reach these objectives. So homeopathic case taking and prescribing flow chart, that is, listen to the patient carefully. We have to discover the cause, we have to confirm with the chronology, translate into repertorial rubric, and integrate with the totality, verify with the Matra Medica, and then only we have to prescribe the simillimum. So 5 golden rules of the causation in homeopathy, that is, every cause is not a repertorial causation. Never prescribe on the causation alone. Then chronological relationship is essential. Confirm every causation, and a guide. Repertory is a guide, it is not a substitute. That is, we should not prescribe only on the single rubric, that is causation. We have to take all the totality. So cause to cure, diagnose what the patient has. That is W. First is a what, when, why, where, which, and how. First in what, that is what we have to cure, what is there in the case we have to cure. Then second, when, that is when the illness has begun. Why we have to ask, that is why that particular disease has developed. Then where we have to search this, all this, that is in repertory. And which remedies to prescribe, that is depends upon the Matra Medica references. And how, that is how we have to individualize the case. So the patient gives us the story, Dr. Hahnemann gives us the philosophy, the repertory gives us the pathway, the simillimum gives us the cure. Thank you.
Thank you, Dr. Vaishali. Hegde, it's really an amazing session, and congratulations for your excellent session. Nobody has done such a presentation on causation so far in this webinar sessions, but it's a full, you really A to Z about this presentation was absolutely right. And this shows the power of knowledge and the power of beauty of homeopathy. If everybody practices in this way, you can definitely a winner, just like an Olympics gold. You can achieve the target in that way with the homeopathic simulacrum. And since there is no only very few minutes remaining, I am inviting the participant to have a question and answer session. And those who want to participate may raise your hand so that we can have a question or chat with Dr. Vaishali. Yes, I'm inviting Vipul Kumar Pandey sir to begin the session. Yes, sir. You can. Sir, please, you are.
Am I audible?
Yes, sir. Now audible.
Actually, as you told, sir, congratulations to Vaishali madam. It is an excellent presentation, concise, precise, and as you told that every physician must follow this type of rule to select a remedy. So again, congratulations, madam. And about the causation, you have covered the aphorisms, aphorism 5, aphorism 7, 94, etc. And one thing I want to add on, that is from the Stuart Close philosophy, that is law of causation. So
Yes.
Dr. Stuart Close has mentioned that for every given effect, a single cause is not responsible. There are series of causes is responsible, as Vaishali madam told, that don't prescribe on the basis of causation only. So wonderful, madam. Again, you have covered the miasm, that is fundamental cause, accessory circumstances mentioned in aphorism number 5, which is mentioned in aphorism number 7. So we must consider the physical constitution, mode of living, sexual life, everything you have covered. And in a short duration, you have mentioned 6 cases with different causes to justify the importance of law of causation. That is best. So it gives a good impression in our mind, and I appreciate your approach, and I think that you are a good teacher in your college, and definitely you definitely satisfy your student, and the students, they will be satisfied by your teaching. And even you are covering the CBDC pattern of presentation, competency based dynamic curriculum. That means your objectives, outcomes, and why it is necessary, how we will find out the cause. Without cause there cannot be any effect. If you remove the cause, then effect will be automatically removed. So this concept you have kept in your presentation. Really, the presentation is wonderful and concise. Second thing, in the last case, the case that you have presented about the tinea, so it is marvelous case nowadays because of lifestyle. Such type of case are obviously coming to the clinic. So, and it is very difficult to cure this type of cases. So if proper diagnosis, proper evaluation, proper analysis, proper reportation will be done, this type of case can be handled. If you will apply external application, then definitely it will be go to suppression. So being a teacher of repertory, and you justified the use of repertory, of course, as you know that our Mathematica is the storehouse, organon is the chartered map, and repertory, that is the compass. So within a short period or short duration, you can reach to the remedy if you will follow the repertory. But no repertory is complete. So we have to, after selection of the medicine, after repertorization, we must coincide or correlated with Mathematica. So Mathematica helps us to finalize the remedy that you have told in your presentation, that is good. Second thing, you have compared about different stalwarts about the causation. That means the causation mentioned by Kent, the importance of causation, that means mental cause, then Boger pathological, then Bonning-Wilson concomitant, etc. So as per the case is concerned, accordingly we have to find out the cause and we have to select the remedy. Again, you have emphasized the fundamental cause. Of course, on the basis of exciting cause, if you treat the case, then the case may not be completely rooted out. So after exciting cause, you have to consider the fundamental cause also. And as mentioned by Hahnemann in 77 aphorism regarding maintaining cause. So maintaining cause, if it persists, this is the main obstacle to cure. So we have to find out the maintaining cause, and you have mentioned in a tabular form different type of maintaining cause related to physical, related to mental. So this type of approach is a very good approach to find out the maintaining cause. So the pseudochronic disease itself does not require any type of medicine, as mentioned by Hahnemann in 77 aphorism. So all the pseudochronic diseases can only be removed if you remove the maintaining cause that you have mentioned, presentation. So I am thinking you have not left anything. So this type of presentation must come in our IBPH. Then we'll be happy to see the presentation. Thank you very much, madam, again.
Yes. Thank you very much, sir. Sir, our session is about to finish, so I'm thanking Dr. Boblim. You can say the vote of thanks to the session, Dr. Vaishali. Yes, Dr. Boblim, please unmute. Yes. Yes, doctor.
Okay, I'm in my car now, just parking. So I just enjoy this session. It is a very, very a detailed description on case taking and the aspects of the through the various gurus in homeopathy from Bonnielsen, and this Hahnemann, and it is a very informative session tonight. I would like to congratulate the doctor tonight. How do you pronounce that, doctor?
Vaishali.
Dr. Vaishali Shinde.
Thank you, sir.
Yeah, it's a bit hard for me to pronounce. As the doctor, you have done a very good job, and congratulations and thank you once again on behalf of IFPH, and thank you very much. Over to you, Dr. Daniel.
Thank you, sir.
Thank you, Dr.
I tried my best, but there might be so many mistakes with my presentation. Please
No
consider
problem.
it.
Yes, there is nothing wrong with your presentation, and hope that you can have some more presentation in September or this October as per your convenience later. So thank you, Dr. Boblim, Dr. Vibhu Kumar Pandesar, and Dr. Vaishali Shinde, and those who attend the English session tonight. Thank you all. Good night. It's over to, before that, tomorrow we will have a session from Dr. Beatrice Gressner. She is from Germany. We'll be talking about organon, her view on organon. So hope there will be a philosophical point will be discussed. Hope Dr. Vishali will also join with us tomorrow. Thank you all. Good night. Over to Dr. Vishaila to moderate the Malayalam session.
Thank you, Dr. Dhanesh.